So I have the absolute honor of introducing the keynote presentation entitled Keeping It Real and Spinning the Wheel, Navigating Paramedicine's Latest Challenges. Our keynote presenters are certainly no strangers to paramedicine and have been in the thick of the challenges that all paramedic systems are facing in this post-pandemic world. Dr. Mark Mackenzie is an emergency physician practicing in Edmonton, Alberta, and presently the Senior Medical Director for the Alberta Health Services EMS system. Mark has been instrumental in implementing evidence-based clinical care in AHS EMS and also helping to build the research enterprise in paramedicine. And Joe Acker is the Deputy Secretary for Community Mental Health and Wellbeing for the Department of Health in Tasmania, Australia, which includes Ambulance Tasmania, where he was Chief Executive for 2 years. Joe is also well known in paramedic circles for his leadership in Alberta and BC and his work as an academic and in research. Originally, I had reached out to Mark and Joe, asking them to dish dirt on each other so that I could make public some juicy gossip, perhaps even embarrass them a little bit. Instead, what I got was a really nice, heartfelt email about the power of relationships in healthcare. You see, Mark and Joe effectively grew up together as professionals. They started as paramedic and physician on STARS Air Ambulance in Alberta. They used to see each other in the ED as Joe handed over patient care to Mark at all hours. They taught together, delivered simulations together, and eventually both of them moved into leadership positions in Alberta, first with STARS and then Alberta Health Services. They stayed close, sharing information and supporting each other while Joe went to pursue his academic and research career in New South Wales, and continued their professional collaboration while Joe was a senior leader in BC and Mark the Senior Medical Director in Alberta. This continued when Joe went to Tasmania, especially during the pandemic, where they would each learn from what their respective systems were doing. To this end, what Mark and Joe demonstrated is the power of relationship and friendship to build not only strong local systems, but also global information sharing, which is critical to disseminating and implementing best practice and knowledge from research. I think it is only fitting then that this is the last official speaking engagement Joe will have in his paramedic career as he embarks on a new journey. In many respects, we have the honor of witnessing this pair come full circle from green paramedic and physician, respectively, to experienced and well-respected leaders. On behalf of the organizing committee of the second annual Canadian Paramedicine Research Day and my co-chair, Dr. Ian Drennan, I want to personally thank both Mark and Joe for agreeing to provide this year's keynote presentation. As someone who has worked over the years with both of these gentlemen, I can attest to their skills and experience as leaders, but also their commitment to building the paramedic profession. I want to thank them for demonstrating what can happen when a paramedic and physician collaborate and mutually respect each other. So Mark and Joe, please take it away.
Thanks very much, Ian, for that very generous introduction. If I could just take a moment, I'm in Nipaluna, Hobart, Lutruwita, Tasmania. Right now it's 2 o'clock in the morning, and I'd like to acknowledge the traditional custodians of this country, the Muwinina people, who I deeply honor their ancestral connection to this ancient island, and I extend my sincere respects to their elders past and present, and to all First Nations people joining today as well. I also express gratitude for their custodianship of the sacred lands, the waters, and the communities, and sincere appreciation to have the opportunity to speak with Mark today.
Yeah, indeed. Thank you as well. I will just give everybody a happy National Paramedic Services Week and thank all the paramedics who have joined today for all the work that you do for your communities. Joe, do you want to introduce the wheel that we have?
Yeah, thanks very much, Mark. So when Mark and I were asked to do this keynote, we talked a lot about what we would do, what themes, what topics, and we had so many things come to mind. One of the things that we really wanted to do was to weave into our talk the 10 principles that guide the future of paramedicine of Canada that was commissioned by the Paramedic Chiefs of Canada. And we'll talk about that at the end of our presentation today. So we thought it'd be really great to look at this conceptual framework and also talk about what it looks like into the future, connecting some of the literature of current day.
No, a conceptual framework is meant to be a conversation starter. It's meant to group people together, and already it's been mentioned in one of the earlier presentations, which was really nice to see. You can imagine that various researchers in paramedicine can identify some of the principles here and group under similar principles to discuss their research. But also even already, Joe, as you and I were preparing for this talk, you could see the value in being able to shape our conversations and our planning for this keynote under various topics. So the term interprofessional conflict has come up, and a framework like this brings interprofessional connectedness. As we talk today about when the wheel spins, and I'm sure people are wondering what the heck is this spinning wheel thing about, and you'll see shortly. But as the wheel spins and we get talking about some of these topics, I would just urge people to, take home whatever points are important to you. Think about them a little bit and get that conversation started in your own communities with your own EMS leaders, provincially, and maybe even internationally, as we're doing here today.
Thanks, Mark. And the 10 principles that will make up this wheel, Mark and I couldn't just pick one or two. We don't have a long time to talk today, unfortunately. So we couldn't do all 10. So we thought we'd just let chance dictate where we go. So we'll spin the wheel and then we'll talk about one of the 10 principles. I think they're going to give us about 8 minutes each to talk about one of those 10 principles. We'll try to link it to some evidence and using some of the, probably cherry pick some evidence to support our positions, our opinions on, and our experiences on those items. And then we'll move on to the next one. So let's see where we go.
If you've ever seen Wheel of Fortune, you know where this is headed.
All right, so continued learning environment. Continuous learning environment.
So I can start out with this one. I think most of the research around here really focuses on adult learning principles, to be honest. And when I think about applying my own professional development as a physician, the thing that's been most impactful is just actually knowing how my patients did. So this is one area that we really, really need to improve on, and whether this is through access to electronic care records, or whether this is making it a priority of the organization to at least reach out for those high acuity events that paramedics are involved in, to let them know how their patient did. And there's obviously some mentorship that can happen. There's some, tips that can be passed along as far as care provided. But honestly, just knowing how your patient did, for me, has been the biggest contributor to my growth in emergency medicine.
And I think, talking about continuous learning, I think that paramedics, we don't particularly have a great relationship or a healthy relationship with continuous professional development in terms of owning it ourselves. A colleague of mine here, Brett Williams at Monash University, and a team in 2019 looked at Australian paramedics' perceptions of continuous professional development. And what they found is that paramedics in Australia understood that there's a need to stay up to date, but they ultimately found that it was they thought that it was the responsibility of the employers to do that, which is a little disappointing to see. As professionals, we need to take responsibility for our own professional development. And when you take that into, as you said, Mark, reflecting on our cases. So the other observation I would make in practice is that ambulance services around the world still largely have a blame and shame culture when it comes to making mistakes or talking about challenges. And we haven't really learned, and I'm speaking very stereotypically, how to be vulnerable, how to ask for feedback, how to ask for our colleagues, our partners, to give us feedback when we've been doing a case or when we're in the learning environment.
Yeah, moving from that blame and shame to just and trust, is one of the when we may eventually get to the role of the physician in EMS systems, and what unique value proposition physicians can bring. But for the most part, medicine has moved to just and trust. I'll say that that's probably always a moving target to actually achieve that. But I think our medical director team has really tried to influence that in the organization here. So, and even separating out the fact that not every little bit of feedback needs to actually go through a patient review process, right? That there is just, feedback you can give for good job. And it starts there, actually. I think to start with the trust part, doesn't always starting if the only feedback that paramedics ever receive is during event reviews or through complaints or bad outcomes or anything. It's not really a good foundation to build trust on. So I think we just have to, build a foundation of mentorship, constructive feedback, giving congratulations and commendation when it's necessary. But that's the sort of the foundation that we're trying to establish in getting to a just and trust culture.
I think that's amazing. And I think we definitely are moving in that direction where we are much more open to that just and trust culture. Jumping back to CPD again, the research is in this space, I think, is important. In 2021, Lisa Hobbs, Scott Devonish, and others, again here in Australia, published a paper in the Australasian Journal of Paramedicine, and it was called Facilitators, Barriers, and Motivators of Paramedic Continuing Professional Development. And I think, all of those of us online, all 564 of us, which is amazing, will know ourselves what prevents us from learning or what stops us, the barriers that get in the way of our professional development, but also the things that facilitate or help us get there. And probably not surprisingly, the barriers include the cost of professional development, the workload or fatigue associated with our full-time jobs, the location of where we can access professional development, rostering, lack of incentives to engage, lack of employer support, and technological problems. But interesting, the facilitators include when the organization supports paramedics to do continuing professional development, improved clinical knowledge, so paramedics wanting to learn something new so they can apply it to their practice and improve patient outcomes, self-directed learning opportunities, and perceived relevance of content. Having worked in 2 jurisdictions in Canada and several internationally, Canada has such a variety of regulatory processes in terms of requiring continuing professional development. Some provinces are very open to allowing the self-directed learning of clinicians, where you can seek your own gaps, fill those gaps with professional development, and submit that for your professional registration. And others are very, very rigid. So I was most recently in British Columbia, and the Emergency Medical Assistance Licensing Board is very rigid on what they will approve and what they won't approve. And I think that's sort of counter to allowing paramedics to develop, because it's not about your own gaps and your own desire to learn. It's about doing the packages that have been approved by a professional regulator. So it's again about maturing this profession, this paramedic profession, so that we're taking accountability for it and we're ultimately responsible for our professional development.
Joe, I'm going to mention one other barrier that I was sort of, it took a while for me to understand in my own system here, and this may be my system, like it's my system, but the system that I'm involved in. But this may be of interest to other EMS leaders that are online. Is just who gives the feedback. I mean, again, optimally, this would be the paramedic, having access to electronic healthcare record, being able to access the patient afterwards, absorbing the information that they're getting about how the patient did to their own existing framework, right? And knowledge about that. But while we're trying to give feedback to paramedics, it's who gives it. Does it go through operations? This has been a real sort of, a bit of a stumbling block for us here. Is the supervisor, for example, still the clinical expert? Perhaps they used to be, but we're in such an operational mess lately, all systems all across the world, that the supervisor has really been, mostly interested in getting bums in seats, right? And, making sure there's ambulances on the road. So I think we're at a point here where we're switching away from that a little bit, and just saying, like, I think the most direct route to the paramedic is the right way to go. Like, it doesn't need to go through a hierarchy to let the paramedic know how their patient did. I think just the most direct route is where we're headed. Anyway, that was a bit of a barrier. I think we're finally overcoming it. But maybe other services would be interested in that comment as well.
Yeah, I think it's a really good point, Mark. And even just talking about providing feedback in the field, we often do see frontline operational supervisors providing feedback, and it's often it's perceived as evaluative and critical and not constructive. And again, that prevents learning, as we get defensive, and we can do better with that by having professional educators that are providing support to our clinicians in the field.
We're over time. Let's spin that wheel.
In the wheel. There's some questions popping in. I think we'll try to get to those towards the end. But
yeah.
Integrated healthcare. I think this is one of my most this is my favorite principle. I'll just, I'm biased here.
We're gonna have fun with this one. So maybe I'll start it with something just a little controversial. I think we all see the benefits. I mean, this is the trajectory where EMS is headed. I mean, there's just no question. I mean, we're integrated in the way that our protocols now are. We lean on in Alberta Health Services, we have a number of scientific clinical networks for clinical experts in emergency medicine and critical care and maternal, youth, pediatric kind of thing, and we lean on them, for example, for our protocol revisions. And the way that helps is that it sort of sets a standard, so that if there's a change, if EMS not making a change, and then you have all the emergency departments saying, "What are you doing? You're making a change. This isn't what we're used to." Everybody's just ready for the revision changes. And so when there's changes to the EMS medical control protocols, they've already been adopted by the rest of the system, so to speak. I mean, there's just many benefits. But I would ask this: what with the problems that we have with offloading right now across the world, what is the point of an integrated system if we can't solve that? And just let me I feel like I'm going to take up another minute or two, Joe, and then I'll hand it over to you. But if ultimately, as an integrated system, if we can't get paramedics back out on the street, then I think it's either not a very mature integrated system, or you really got to look at the integrated system has to look itself in the eye and say, are we really doing the right thing here? One thing that's happened in Alberta just in the last 3 months, so I won't wave the flag of success just yet because it's only just happened, is that all those areas in our 16 biggest hospitals in the province that used to have paramedics, mostly hallways, it's hallway medicine, lining the hallways. There's been motivated partly by crisis, but also from a mature integrated system. I hope this is what we're finally seeing, 10 years into integration. I think what we're finally seeing is that those hallway spaces have been staffed now by emergency staff. And it's honestly been completely transformative for our system. Our average red alert minutes in both Edmonton and Calgary, give or take, are around 500 minutes a month. And we're essentially at zero. Like we've essentially, there was an MCI shortly after this was implemented, where there was 20 trucks sent to a house explosion in Calgary. And I think we were on red alert, like 0 ambulances for 30 seconds. I mean, prior to this implementation, it would have just been, a zoo. So I would reference, to me, the article that pops out to me is Grant Innes's paper on accountability. And we'll post this somehow. But there's also a YouTube that goes along with it, which is actually really entertaining if people haven't seen that. They just need to put the title in their search engine and a YouTube will pop up. And they compare the healthcare system to an assembly line of a car plant. And so the take-home point from that is that we can all be one, we all are one system. We know that we're all affected by the next step down the line, but you still need to have areas of accountability. You still need to own your staff. You still need to have your own budget. You still need to have decision-making capacity. And there is a wedge between what's happening in access block and to paramedics. An access block is all, the patient is in the wrong place. You have long-term care patients on wards. You have ward patients in the emergency department. There's a patient in the wrong place problem for hospital flow, but it's giving EMS a staffing problem. EMS actually doesn't contribute really in any way to hospital flow, either positively or negatively. IFT, interfacility transport performance aside, but just the patients coming in, like whether they hand over to a nurse in the hallway or whether the paramedic stays in the hallway, honestly, doesn't impact hospital flow at all. One just gives the system back to EMS and the other one destroys it. So anyway, lots of success there. And there's lots of work, and I'll just point out that Ian Blanchard just had a publication this month in CGEM, so hot off the presses.
So kudos to Alberta. I think that's amazing. Cracking this nut of offload delay and transfer of care delays has to happen. We cannot provide care to the community when we're stuck taking care of patients in the hallway. There's a paper out of Australia called The Ethics of Ambulance Ramping, and it says that hospitals use paramedics to take care of patients in the hallway so that they don't have a patient risk in the hospital. But what they're not taking into account is the huge risk that happens in the community when somebody rings 000, 911, 999, and there's no ambulance available because it's reducing the risk in the hallway. So we have to stop that, and integrating with health can do that. I'm a deputy secretary of health. I'm responsible for the health system and the ambulance system, and we're still struggling with transfer of care delays. So it is a difficult problem to solve. But as paramedics and as ambulance service, it's also up to us to start doing things differently to prevent things like transfer of care delays. And that's where this integrated care is really exciting. I think the things that we can do in the community, and I see a question from Robin Fennew about palliative care. And I know Jenny Helmer's online, and her, Leon Baranowski and others, Richard Armour, published a paper in 2021 looking at palliative care in British Columbia. And they found that, a fifth of palliative care patients, when paramedics are trained to do palliative care, can be left at home and not transported. Now, 18% is not a huge number. It's not going to stop transfer of care delays, but that helps reduce that load of the hospital, and it's the right thing for the patients. I'll share some stories from Ambulance Tasmania, because we actually are really investing in integrated care. So we have secondary triage, where we have paramedics and nurses in our communication center. It was last month, and we have 2 of them, so it's not a huge center. We do about 350 calls a day, but we screened 919 calls, 414 of those calls, and they're 000 calls that are deferred to secondary triage. 414, or about 38%, didn't have an ambulance response. And really important, 116 of those patients got a taxi. So we sent taxis to pick up those patients and take them to the hospital, the GP, the pharmacist. Now, again, not big numbers, 38, 40%, fewer ambulances responding to that, which keeps people out of the emergency department. Our community paramedics here, and we only have 3 units doing a day and afternoon shift, not huge numbers again, but 236 responses last month, 65% of those patients didn't go to the hospital. Again, not contributing to ramping, treating those patients in the community. We have a police ambulance clinician early response, so a PACER team, which is the mental health early response team. Last month, they did 84 responses, again, 000 calls or 911 calls, and 76% of those patients stayed in the community. Paramedics can be part of the answer to transfer of care delays. We can do much more in the community. That's the right thing for the patient. That's that is also reducing the demand on the hospitals.
Yeah, no question. I think what we're finding, just to sort of tie that together, we also have a fairly new secondary triage process going. Our transport rate or conveyance rate is somewhere around 55% right now. Like, our non-conveyance rate is very, very high. What I think we're witnessing with getting paramedics back out into the community, or at least not getting stuck, is instead of creating, every time we created an ambulance, a free ambulance in the community, all these efforts that we're doing to create more capacity, they just end up getting stuck in the emergency department again, unless you fix that first. So, now that we're actually seeing some really, really good results there, and they're not getting stuck in the black hole or the vortex of the hospital system, we're actually seeing an additive effect. All these initiatives that you're talking about, Joe, they're way more impactful now than they would have been without solving the emergency department offload problem.
I know we got to spin the wheel again, but and I'm so excited about the opportunities paramedics have to provide care differently in the community. But I'm also cautious that we can't be the one size fits all, the Swiss Army knife to solve all the problems of the healthcare system. I think we can. I think we're an incredible workforce that can do just about anything that the health system wants us to do. But should we do that? And I think the answer to that is no. We still have our primary responsibilities to our communities, but we also have to be part of this solution to the changing needs of our patients and the changing healthcare system.
And I think, to your point, where are paramedics' unique value add in the community?
Yes.
So wherever the work is being done, that's where the sweet spot is.
Not standing in the hallways at the hospital.
Yeah.
All right, spin that wheel. Oh, professional autonomy. Well, maybe this is my favorite one. So I've got lots of favorite ones because I'm a real big fan of this, the 10 principles. So professional autonomy for paramedicine. I think, what we mean by this is that we own our practice, that we are professionals. We own our scope of practice. We are a self-regulating profession. But at first, I think we need to ask, are we a profession? And that is not homogenous. I don't think if we look at the world, a paramedic in one country is not necessarily the same as a paramedic in another country. I worked with a brilliant scholar, Tim Mackenzie, who's recently from British Columbia, but now has joined us back in Tasmania. And Tim did his PhD looking at, what are the different types of systems in the Anglo-American paramedic systems. And we talk about Anglo-American, we're talking, England as Anglo, including Australia and New Zealand into that, and then American, which is Canada and the US. And what Tim did through a number of research processes and methodologies was ultimately identify that there's two subsystems of the Anglo-American system. One is the professionally autonomous system. That is where paramedics do have autonomy. They are responsible for their practice. They're responsible for the systems and the services. They're the bosses. They're creating clinical governance. They are consultant paramedics making the clinical decisions. And then there are the directive paramedic systems where usually a medical director is responsible for the system, the processes, the policies, the procedures, the clinical guidelines. Tim's work then went on to say which one is safer and which one actually provides better value. And I would strongly encourage people to read 5 of Tim's papers on this process. But I think where we're at, and this is going to sound, all my colleagues in Canada aren't going to be happy, I don't think we're yet paramedics in Canada are professional. I think we've still got some gaps to where we want to go. Australia is on the way. Back in 2010, Brett Williams published a paper saying, are paramedics a profession in Australia? And his answer at that time was no. Paramedicine in 2010 wasn't a profession because we didn't delineate the professional compass. We didn't do anything that was really remarkably different than other healthcare professions. We were very similar. We didn't have national registration or regulation. We didn't have self-regulation. Every ambulance authority provided their own authority to practice for paramedics. Higher education wasn't absolutely required for entry to practice. So we still had vocational pathways and some higher education pathways. But fast forward, 2018, paramedics became registered and recognized as professions in Australia. And all of those pieces came together. Their scope of practice or their uniqueness is now better defined. They have higher education as the entry to practice. They have national registration and regulation. They're self-regulated with a board and moving towards professionalism. But does that mean they're autonomous? And in other words, does that mean that paramedics in Australia or the UK or Canada or the US shouldn't have medical directors? And I'm going to kick over to you, Mark, to give your opinion on that.
I'm first of all just going to thank you and Tim and Peter and all the work that you've done in this area. I've found the construct of a directive system and a professionally autonomous system just very, very helpful to have, and where you land on that dial, and it gives a target as to where you want to head as a system. So, I mean, in our own area here in Alberta with myself and other nine medical directors, we spent a lot of time in this space doing leadership development initiatives and discussing what actually is the role of the physician in EMS, specifically now that they are professionally self-regulated profession in Alberta. What's the role of the physician? And a lot of it, other than the clinical expert role, which is just sort of where we come from with our backgrounds and our training, we're also enablers if we consider ourselves as consultative, not directive. We can be enablers to actually move the needle towards professionally autonomous. And, just for example, I really enjoyed the debate on should paramedics initiate non-conveyance discussions. And there was a really great comment that somebody made that paramedic education is only part of the success of that. And I agree. When we initiated our general assess, treat, and refer, which is completely different than a refusal, this is actually trying to provide some guidance on safe non-conveyance pathways. And similar to secondary triage, the pathways will grow, right? The referral pathways will grow. Again, it's a foundation. We don't have phenomenal pathways to primary care just yet. For example, can you imagine when that happens through electronic care record and such, just how useful that will be. But one of the key elements that we emphasized when we rolled this out was paramedicine and merit medicine will always be a consultative specialty. So autonomous is not, alone, is I think the point. We can keep talking about expanding paramedic education, getting to it, to bring us full circle back to where we started, talking about individual professional development. So the paramedic has to take professional development on their own as opposed to it being spoon-fed through the organization. But it'll always be consultative. The reason most emerge docs can sleep at night is because if we don't know something 100%, we ask, whether that's a colleague or a specialist or whatnot. So I still think that's another role for the physician in EMS at this point, is to enable non-conveyance decisions. It was really interesting when you and I were preparing for this, Joe, you had mentioned that despite the higher level of education that paramedics have in Tasmania, your conveyance rate is really much higher than it is here. And we were sort of trying to figure out why that might be, whether it's more litigious or leading to conservative practice the same way that we see in medicine in the US, or what was it? But maybe just talk about that. What is the conveyance rate? You said it was.
So I've got the data right in front of me. I just pulled it up, Mark. So we have the report on government services. So all ambulance services have to report to the federal government all of our data every year. It's the Productivity Commission. So the services are all provided on here. So Queensland Ambulance Service does 1.2 million calls a year. It's huge. 87% of those patients are transported to hospital, which is on the higher end.
Wow.
Our service, we're talking about 77%. So between 77 and 87% of patients in Australia are transported. So nowhere near the 55, 60% you're talking about in Alberta. Part of that reason is that paramedics don't typically consult with doctors in Australia. They have clinical practice guidelines. They have their own authority to practice in terms of national registration, and they're expected to just go get their work done. But they're not comfortable with that necessarily sometimes. So they are much more conservative because they're carrying their own indemnity insurance. Their registration regulations are going to hold them accountable. So it's just much easier for paramedics to transport patients to hospital. Where I believe, and I agree with you completely, I think if we increase the ability to consult with somebody else, it builds confidence, and it also allows us to make sometimes more challenging decisions. Still be conservative and safe, but perhaps make decisions because we've got some validation from a trusted colleague or certainly somebody who's a specialist in the space.
Yeah, that's right. And we do track the outcomes of those, but we really, again, ultimately, and this is getting back to one of the first principles that we talked about, ultimately, if a paramedic doesn't transport a patient, they would look up themselves to see how the patient did, right? Like, a week later, is that patient still at home? How did they do? Did they end up going to hospital, whatnot, something like that? So, okay.
So one of the questions, interesting. So not all states in Australia are the same, certainly, but in Tasmania, our paramedics actually have access to the digital medical record. So we can look up the patients that we've transported and see what happened to them in real time. We have access to the digital medical record for the state.
Yeah, that's
which is amazing. Amazing way to validate.
That's something
we have lots of privacy concerns. I have to say, we have lots of violations of good access. Just on this same one, though, this autonomy question I think is so important. And I think you and I are the perfect people to talk about this, because as a paramedic myself, as a physician yourself, who've worked together in many different roles, I am a roaring advocate for paramedic autonomy. I love the concept of consultant paramedics overseeing systems, having PhDs, having expertise in an area. In Australia, just this last month, their Commonwealth, the health minister challenged the ministers of health of every state to bring in paramedic practitioners into practice for rural and remote practice to support GPs and primary care. And they're lobbying the regulator to allow a paramedic practitioner scope of practice. Currently in my job right now, I have ambulance as part of my portfolio, but I also have the pharmaceutical board and the chief pharmacist. And I think it's exciting that paramedics could have prescribing rights. We need that. And I'm all about autonomy, but to get there, we need other clinicians. We need the support of pharmacists. We need the support of GPs. We need the support of nurse practitioners and physiotherapists to develop those skills. Those aren't things that we have right now. If we're going to have paramedic practitioners prescribing and working in the primary care setting, they need to learn from GPs and other clinicians. So I think, we are, I believe, moving to the area of autonomy, but we're going to be a multidisciplinary service, and paramedics are going to be leaning on their colleagues in other health professions for a long time to come.
Yeah, and last comment from me, just based on a comment that I saw pop up, and just paraphrasing that. I think somebody said essentially it's not all about transport or non-transport, and I completely agree with that. Getting to your point, really what we're talking about is helping patients navigate the system. Right, we've talked about transport or non-transport, again, talking about the operational impact, but we should bring it back to patients at the end here before we sign off. It's all about what's best for the patient. What's best for the patient is not always transport. Having somebody in their living room to help them navigate their healthcare needs is what's best for the patient and the system. And how are you going to do that without interdisciplinary interactions? As you say, pharmacist, emergency physician, palliative care physician, you name it. You're going to be interacting with physicians of all sorts.
Yeah, and those professions can make us a better service, a safer service, and a service that can offer a much wider set of skills and services to the community. Ambulance Tasmania right now, we have nurses, physicians, pharmacists, paramedics of different levels, providing largely the same services. We have nurses and paramedics working side by side. And I got to speak frankly, the best part of my career, where I think we provided the best care, and I've been doing this for over 30 years now, was when I was in the back of a helicopter at STARS with you and a nurse. A doctor, nurse, paramedic team, I think, is an ideal team to provide critical care. You bring so many different perspectives to patient care. I learned so much as a paramedic, and I think that as a team, we continuously learned as we were refining our practice together.
Okay, Joe, we better hand it back to the organizers before we get in trouble. Thank you for doing this with me, and congratulations on your really successful career in paramedicine. I somehow doubt that you're going to retire, although congratulations on your first run at retiring. How about that?
Well, it's now 2:48 a.m. on Friday in Tasmania, and this is my very last day of work. Yeah. So I am getting on a plane on Sunday, leaving the state, and I'll be back in Canada for a lovely summer where I plan to ride my motorcycle and just enjoy life for a little while.
Congratulations. We're going to give Walter the very, very, very last word. Joe, why don't you start the...
Sure.
Yeah.